The next part of biomechanics is looking at what we refer to as force couples, and this is often done with the muscles we refer to as the rotator cuff. And we'll talk about how the rotator cuff and also some of the slings or the fascial slings I talked about with the pectoralis major in front and the latissimus in back, they work together to be able to provide dynamic movements and dynamic stability of the shoulder girdle. Let's take a look at how this works. The rotator cuff consists of muscles, the supraspinatus up on top, the infraspinatus underneath, the subscapularis in the front of the scapula, and then the teres minor that comes along the border. Now these muscles, when they work together, create what's called a force couple, and they actually approximate the head of the humerus into the glenoid fossa, which is maintaining congruency. That's why it's so important. Now during shoulder flexion, the rotator cuff compresses that glenohumeral head, that joint, in order to allow the deltoid the power to lift the arm up. Now you might have seen this before. When somebody has a shoulder injury and the rotator cuff doesn't work, they'll actually use their trapezius muscle to lift the shoulder up, and then they lift the arm up like this, right? And what should happen is the rotator cuff actually depresses the humeral head and abducts the arm just about 30 degrees so that the deltoid muscle up on top can pick that arm up in a normal and healthy fashion. So again, if you see somebody doing this, you know their substituting rotator cuff is not working. If you see somebody doing this, where that arm comes up naturally, we know that that rotator cuff is approximating, depressing, and working as a force couple to create the congruency necessary to do overhead activities. Force couples, again, when we look at the force between these muscles, are equal in magnitude. And when they work together at the same time, they actually will rotate the humerus in the glenoid fossa. So if you look at the little skeleton I have here, the muscle in front and the muscle in back act a little bit like a sandwich, it's referred to in the shoulder, and it's going to create that rotation of the humeral head inside the fossa of the glenoid without displacing it or subluxing the humerus from the scapula. Another really important force couple in the shoulder girdle is that of upward rotation and downward rotation. The muscles involved in the upward rotation force couple are the upper and lower trapezius as well as the serratus anterior. And what happens here is that the trapezius muscle is going to actually rotate or spin the scapula on the axis as the serratus anterior actually pulls it a little bit into protraction. So what that's going to do is it's going to open the glenoid fossa upward and allow for good congruency with overhead activity. So if you are lifting your arm over your head, that force couple of upward rotation is going to place the scapula in an ideal position to maintain congruency while doing overhead activity. The last force couple that I want to talk to you about in the shoulder is downward rotation, and this is made up of three muscles: the pectoralis minor in front, the levator scapula and rhomboid in the back. And their primary purpose is to be able to rotate together the scapula inferiorly so that we can maintain congruency with the head of the humerus and the glenoid fossa. Now this would be in activities like pushing myself out of a chair or a bar dip where I'd be pushing down with my arms. And again, if that scapula moves in that inferior rotation, it's going to provide better congruency and minimize risk of injuries with those types of activities. Now when we look at the upper and lower trapezius, it's very important for us to understand that there's a relationship. And there's a lot of exercises that we teach in Pilates that specifically look at the organization of lifting our arm up over our head. And there's a lot of literature out there. I remember early on in physical therapy school, we talked about doing the strengthening for the supraspinatus by doing what we call an empty can test or a half-empty can test and strengthening exercises. And I always was impressed with the fact that people always sort of lifted their shoulder up while they were doing it. And as it turns out, there's research now that shows that we really don't want to be getting or trying to strengthen the supraspinatus by doing an empty can test, but rather doing a full can test. And so a lot of times what we're actually looking at is the alignment of the humerus. And a good little rule of thumb, as you can see in this slide, is that the humerus is lifting up, whether it's in prone or standing, doesn't matter so much, but the humerus is lifting up in the same line as the angle of the scapula down into the lower trapezius. We're probably in a very good and safe angle, and we're going to be able to strengthen that that supraspinatus, especially as we're in a little bit of external rotation in that arm. We also talk about the bicep long head, and this is one of the most common injuries in the shoulder is impingement of the bicep long head. And the bicep tendon can slide as much as 6 centimeters through the groove in the shoulder. It's also unique in the fact that it's one of the only body parts where the tendon actually goes up and over the bony attachment and goes through the capsule and attaches onto the labrum. So a lot of the labral tears or slap lesions that we hear about in sports injuries is this very essence of the bicep tendon's attachment to the glenoid and the labrum. And so one of the things we see quite often is in throwing sports. I had a case with pole vaulting. A lot of you know I'm interested in pole vaulting, where this tendon has actually ripped the labrum off of the glenoid fossa, and then you lose a congruency, you lose stability in the joint, and of course a lot of pain and discomfort. So when we look again at how that happens, it's going to happen because of a loss of congruency and an excessive force. So one of the things we want to always try to look at when we're working with our clients is make sure when we're doing overhead activities that we are going back into extension, those kind of activities at end of range, that we don't lose congruency. Even with some of the simple movements in end of range can do damage by the power of this tendon pulling on that labrum and can cause problems with patients in the future. Another area that's really interesting to me is the pectoralis minor. I often call this the emotional muscle. And when we think of adolescents developing, often what they'll do is they'll over-recruit that muscle to either more like an introverted posture, we'd say, if they're going through puberty, developing breast, or they're not growing as fast with some of the young men as other young men are, they'll go into this posture. And the problem with that posture is that there's this huge vascular bundle and neurovascular bundle that passes underneath the pectoralis minor. So if that muscle is really tight and it's pulling forward, the brachial plexus and the brachial artery can actually be compromised if it's been tight or restricted for a long period of time. And so this is one of the things we like to look at with our clients in Pilates is we're always talking about posture and opening that area up. Sometimes we even send them for myofascial release because they've been in that posture for so long that they now are having some pathology. So when we look at the brachial plexus and the complexity of it as it comes underneath the clavicle and also underneath that pectoralis minor, it becomes really imperative to us to understand how posture can affect the health of even our brachial plexus and the nerve bundle in our arm. This nerve bundle feeds all the sensory and motor of our upper extremity. And I can't tell you how many times I've had patients who have come to me with numbness and weakness in their arm thinking they had a disc problem in their neck that turned out to be just poor posture and a tight pectoralis minor over the brachial plexus causing some of those symptoms in their arms and their hands. I've also seen the misdiagnosis of carpal tunnel and cubital tunnel syndromes that also result of poor posture around the shoulder girdle. So one of the things we want to focus on in Pilates is being able to keep that space open. And the cue that I often use is thinking of having a smile just as wide on the front of the chest as there is across the back of the shoulders. So we avoid collapsing in the front and we also avoid overextending in the back. So a nice balanced look in the posture of the body. Another concern that we often talk about is differentiating between hypermobility versus instability. Now, hypermobility is not necessarily a bad thing. We have many elite athletes and performers and dancers who experience an excessive range of motion in the normal bell curve. They'd be on the outside of it. What the difference is between it being unstable or stable is whether or not they have control over it. So I've worked with dancers and performers from Cirque du Soleil and professional ballet companies who have a lot of mobility. But the beautiful thing is that they have control over that mobility and they have access to that movement. When they lose that control or lose that access, now that hypermobility actually becomes instability. Another way of looking at it is that any joint that doesn't have control could be considered unstable, because the real essence of the word is control, and that's what Joseph Pilates taught, was contrology. That's what we do in Pilates, is we teach people to control. So we don't want to make such a big deal about hypermobility as much as we make a deal about having control of the movement that you have. I often think of the dancer that spends hours stretching their hamstrings, and they can bring their leg up around their head, but when they stand up, they can't lift their leg higher than 90 degrees. That would be an instance of instability because they don't have control over the mobility that they have. One of my jobs would be as a Pilates teacher would be to give them control over the range that she now has. So if she can lift her leg up to 130 degrees, or has the flexibility to 130 degrees but can only lift to 90 degrees, I'd want to teach her how to get her leg to move through that 40 degrees that she doesn't have control over.